Hello everyone, I'm Salva and today we'll be seeing about anti-epileptic drugs. This is an important topic for university exams and NEET PG preparation. First, I'll be telling about seizures in short and then about the pathophysiology of each seizures so that it'll be easy for us to remember the mechanism of action of each drugs. So let us start. So seizures in short, there are three types of seizures: generalized seizures, partial seizures and juvenile seizures. In generalized seizures, we have generalized tonic-clonic seizures, myoclonic seizures and absence seizures. And in childhood, we have Lennox-Gastaut syndrome and Dravet syndrome. For pathophysiology, I'll explain you in short using diagrams. Let us imagine this is the brain and then we have the spinal cord behind. First, there will be activation of T-type calcium channels. This T-type calcium channel gets activated of no reason, and then there will be generation of action potential. For the propagation of action potential, sodium channels will get activated and then there will be further firing to the spinal cord. This will be from the thalamus and then it will go to the spinal cord. Now we'll see the pathophysiology. So in GTCS, the T-type calcium channels will get activated via thalamocortical reciprocal firing, and then the sodium channel will propagate the action potential, and then there will be spinal cord depolarization, followed by which there will be muscle contraction, tongue biting, and then teeth clenching and urinary and defecation, which happens involuntary. And then in absence seizures, there will be T-type calcium channel activation. Just the T-type calcium channels, because if there is propagation of action potential, there will surely be contraction of muscle. And we also know in absence seizures, there will be just blinking and staring and the child will be absent from the surroundings. So here there will be only generation of action potential from T-type calcium channels. And in partial seizures, there might be some space occupying lesions that will lead to sodium channel activation, and there will be localized depolarization. Wherever the space occupying lesion is there, there will be localized depolarization, hence the localized muscles will get activated and they'll start to contract. So I'll tell you the pathophysiology in short. GTCS, T-type calcium channels gets activated. For the propagation of action potential, sodium channels will activate and then depolarize the spinal cord. In absence seizures, there is only involvement of T-type of calcium channels, and in partial seizures, there is involvement of sodium channel. Now, why did I tell you this? Because the importance of blocking the sodium channel so that the seizure does not get progress further. So now we'll see about the sodium channel blockers. In this, we have three classes, that is Phenytoin, immunostilbene and phenyltriazines, and then some newer drugs. In Phenytoin, we have Phenytoin and phosphenotoin. In immunostilbene, the name bene and carbamazepine, they both sound similar. So remember carbamazepine and the two prodrugs, oxcarbamazepine and eslicarbamazepine. And in phenyltriazine, we have lamotrigine. What are the newer drugs? Topiramate, lonesamide, lacosamide, rufinamide. You have to remember these drugs. These drugs are the sodium channel blockers. So amongst this, Phenytoin is an important drug to be read. I have written Phenytoin's mechanism of action, pharmacokinetics, uses and adverse drug reaction in one page, so that it will be easy for you to revise and just write it in the exams also. And here the adverse drug reaction is very important for a NEET PG examination because they have asked many MCQs from this. So let us start. So Phenytoin is also known as diphenylhydantoin. It is an enzyme inducer. This drug limits the spread of the seizure. If there is a seizure right now, it will stop the progression of seizure. It is because Phenytoin simply blocks the sodium channel and then the progression of seizures is stopped. So now we'll see about the mechanism of action. It binds to the voltage dependent sodium channel and also it reduces the intraneuronal sodium concentration. Other actions are, it decreases the presynaptic release of glutamate. So glutamate is an excitatory neurotransmitter. So if there is more excitatory neurotransmitter, there will be more muscle contraction. So here it is self-understood that it will inhibit the presynaptic release of glutamate. And then it will increase GABA. GABA is an inhibitory neurotransmitter. So inhibition of contraction will facilitate to stop the seizure. And then there will be decreased calcium influx. Now we'll see about the pharmacokinetics. It is metabolized in liver by hydroxylation and glucuronide conjugation. And elimination of the drug depends on the therapeutic range. Means if the drug is in low concentration, it will follow first order kinetics and the T-half is 24 hours. If the drug is high concentration, that is, it can lead to toxicity. The enzymes get saturated when there is more than 10 microgram per milliliter plasma concentration of the drug. The T-half becomes 60 hours. It is highly toxic. Now we'll see about the uses of Phenytoin. Based on the route, on oral route, it can be used for GTCS and partial seizures, and if IV route, we can use it for status epilepticus. And it is a second drug of choice for trigeminal neuralgia. Now, we'll see about the adverse drug reaction of Phenytoin. This is an important topic for NEET PG exams also, so just see this part. The mnemonic here is Hydantoin. So H stands for hirsutism, Y stands for hyperplastic gum and hyperglycemia, D for diplopia, A for ataxia, N for nystagmus. T stands for teratogenicity, that is cleft lip and cleft palate, O for osteomalacia, I for increased bleeding in newborns, N for neutropenia. And now here, amongst all the anti-epileptic drugs, valproate is highly teratogenic and lamotrigine is the least teratogenic drug. To prevent osteomalacia, vitamin D can be given to the child. And to decrease the bleeding in newborns, vitamin K injection is given immediately after birth. So let us summarize. Phenytoin is also known as diphenylhydantoin. It is an enzyme inducer and it limits the spread of seizure. Mechanism of action, it binds to the voltage-dependent sodium channel and reduces the intraneuronal sodium concentration. Other actions, it decreases the presynaptic release of glutamate, it increases GABA levels, it decreases the calcium influx. Pharmacokinetics, it is metabolized in liver by hydroxylation and the elimination of drug depends on the therapeutic range. Lower concentration, it follows first order kinetics and in higher concentration, it follows zero order kinetics. Uses. It is based on the route. If it is given via orally, then it is used for GTCS and for partial seizures, and if for status epilepticus, it is given via IV route. It is the second drug of choice for trigeminal neuralgia. Adverse drug reaction, just remember the mnemonic hydantoin, in which H stands for hirsutism, Y for hyperplastic gum and hyperglycemia. Diplopia, ataxia and nystagmus are symptoms of acute toxicity, and then this is a teratogenic drug. It can lead to osteomalacia, that is softening of bones, increased bleeding in newborns and neutropenia. I hope you understood this topic and I hope it's very short so that you can write easily in your exams. Please hit the like button, subscribe our channel and hit the bell icon, and we'll be next continuing about valproate and followed by management of status epilepticus. Thank you.